Hello, everyone. Welcome back to the next episode of the clinical topic series. And today we are going to discuss about pericarditis. So, Lakshay, what exactly is pericarditis? Can you explain what is pericarditis?
So essentially, pericarditis is just inflammation of your pericardium, which is the outer layer of the heart, without the involvement of myocardium or a drop in your ejection fraction. So it should just involve the pericardium, then we'll call it pericarditis. If there's any involvement of myocardium, we call it myopericarditis. And there should be no drop in ejection fraction for it to be just pericarditis. So pericardium is actually the outermost layer of your heart, and
Mhm.
anatomically it prevents spread of infection, spread of malignancy, and just preserves the position of the heart.
Okay. So, what are the common features patients present with when they have pericarditis? What are the common symptoms?
Typically, they're present with chest pain, and we should always consider of other life-threatening causes of chest pain like PE, ACS, dissection, esophageal spasm, or Boerhaave syndrome. We should always think about them. And pericarditis, again, presents with chest pain. Now, it can be described as sharp chest pain, sometimes pleuritic chest pain,
Mhm.
or a bit positional. Often patients say it radiates to the trapezius or to the back. It's kind of an important finding. And because of the stretching of pericardium, it can get worse when they bend backwards or when they lie down flat spine, and it can get better if they kind of set up or lean forward because of the relaxation of the um, pericardium. This is the classical history, but you may not always get it. And also, it's good to ask about any preceding flu-like illness,
Mhm.
respiratory, or any GI symptoms in the preceding 2 or 3 weeks,
Okay.
which can often be the trigger for idiopathic viral pericarditis, which is the most common cause of pericarditis.
Okay. So, you mentioned about idiopathic or viral pericarditis. What else can cause pericarditis? What are the other causes of pericarditis?
So as I said, viral is the most common if we don't know the cause, and if the
Mhm.
patient is otherwise well, with no worrying comorbidities, we
Mhm.
presume it to be viral idiopathic and treated like that.
Yeah.
The other important causes of pericarditis can be post-MI
Mhm.
pericarditis, which is called as Dressler syndrome, which can
Mhm.
come after a couple of weeks of ischemic cardiac event.
Mhm.
Connective tissue diseases can cause pericarditis, things like SLE.
Mhm.
Trauma can cause pericarditis. It
Okay.
can have metabolic causes like uremia, uremic pericarditis, which is an indication for dialysis.
Mhm.
Um, Neoplasms,
Yeah.
cancers can cause effusions in pericarditis. So
Yeah.
basically, it's infectious,
Yeah.
can be bacterial, viral, inflammatory, neoplasm, trauma,
Yeah.
post-MI, and metabolic like uremia. So these are the really important ones which can cause pericarditis. It's good to mention that uremic pericarditis may not have
Mhm.
ECG changes. We'll
Okay.
come to that in a moment. We can talk about the ECG changes that we see in pericarditis.
Okay. To add on to that, if I'm correct, I think if in places where it is prevalent, tuberculosis is one of the causes for bacterial pericarditis as well.
Yes, that will come under the umbrella of infection,
Yeah.
viral bacterial infection. Yes, it can cause,
Perfect.
and that's probably one of the reasons to admit someone if they've got a tuberculous or a purulent pericarditis, if they've got temperature with that.
Okay. Perfect. So you mentioned about the clinical features of pericarditis. How would you diagnose pericarditis in the emergency department? Is it a purely clinical diagnosis, or do you do any specific tests to aid your diagnosis?
I think tests are often done to rule out other potentially life-threatening causes of pericarditis. In terms of clinical features, as I mentioned, you may get a classic history of chest pain, sharp pleuritic, both on lying flat and better
Mhm.
bending forward, going to trapezius, pain radiating to trapezius. So there are four things. Like there is a diagnostic criteria which consists of four elements. So one is classical history.
Mhm.
The other is you may or may not hear a pericardial rub, which can
Mhm.
be a transient finding,
Yeah.
unfortunately, and can be difficult to appreciate as well.
Yeah.
Um, but it'll be, you will hear that with the heartbeat,
Mhm.
not with the respiration. If you hear a rub with the respiration, that's probably pleural rub,
Mhm.
but pericardial rub, you will hear that kind of a squeaking, scratching sound with
Mhm.
every heartbeat.
Perfect.
So that's the second thing. The third thing is ECG. You may see ECG changes. Now, depending on which stage of pericarditis they are at, there are different stages of ECG changes. And the last thing is they may have a new fusion. They may have a worsening of fusion. So classical history, pericardial rub, ECG changes, and effusions. These are four things. They need to have a couple of them to call it pericarditis.
Okay.
We should actually put the probe on everybody who's coming with chest pain. If we are thinking of pericarditis, obviously, yes. If they've got tamponade, that's very helpful. That buys them an admission.
Okay, perfect. You mentioned briefly about ECG. Can you talk a bit more about what are the ECG changes that you're looking in a patient in whom you're suspecting pericarditis? Are there any very specific ECG changes, or are there different ECG changes when looked at together? Probably gives you a bit more of idea that it could be pericarditis.
So there are many things which can cause ST elevation. STEMI is the most common one that we think about. We should always correlate ECG with the history.
Yeah.
So if I see ST elevation in a 22-year-old with a history of viral fever or flu-like illness a couple of weeks back, I wouldn't call it STEMI. I would call it, it's got ST elevation with preceding viral illness, so probably pericarditis. Sometimes it can be really difficult to differentiate. And from the data I was looking at, about 1 in 5 patients actually end up going to cath lab to figure out what's happening, and because we don't want to miss ACS. In terms of ECG changes, they can have ST elevation with PR depression in multiple leads. They can have PR elevation in AVR. So they can have ST elevation with the PR depression in multiple leads. So ST elevation, that's typically the stage 1. There are again 4 stages. So ST elevation and PR depression is the first stage. And the second stage, they can have normalization of ST segments and PR segments. And the third stage is when they can have T-wave inversions. And the fourth stage is when everything settles down, or they may have persistent T-wave inversions. So they can present at any stage. Most commonly, we think of this diagnosis if they come with ST elevation. Just to briefly mention about PR depression. PR depression does not rule out ACS. ACS can very well have PR depression.
Okay.
So with ECG can suggest this. ECG is not 100%. Also in pericarditis, what they describe is the ST elevation in lead 2 is more than lead 3.
Okay.
And in STEMI, lead 3 is more than lead 2.
Okay.
And again, this suggests this is not 100%. One thing, the really important ECG finding, if you want to remember one finding, is that will be ST depressions.
Okay.
If somebody has got reciprocal ST depressions, that's ACS, unproven otherwise.
Okay, perfect.
There's another sign which is sometimes described as pericarditis, that's called a spodix sign. That is essentially the down sloping of the TP segment. So between the T wave and the P wave, the TP segment sort of comes down rather than going straight into the P wave. The T wave kind of slopes down. So we'll leave a link in the description of this video about the ECG changes. But they can be quite non-specific. We should always think of ACS, but it's generally 4 stages.
Perfect. Add on to that, I think if you just talk about the ST elevation itself, it looks slightly different to that of ST elevation of ACS. So probably there is more of concavity upwards, which is unusual with ACS, if I'm correct.
Yeah, I think if there are multiple things suggesting pericarditis, if there are ECG changes, sometimes it's worth speaking to cardiology and have that sort of shared decision making rather than making this decision alone, because the stakes are really high. If the troponin comes out to be like 2,000, and we don't want to miss ACS, we don't want to delay it. Time is muscle. So if you have any concerns, any doubts, speak to cardiology. But ST depression is one sign that I would definitely remember. Reciprocal ST depressions.
I think to summarize all of it, so there are multiple ECG changes or characteristics which might suggest that this is more likely to be pericarditis, but there isn't one sign or one ECG sign which can kind of completely rule out ACS.
Absolutely,
Perfect. Okay. So moving on further, would you want to do any other investigations in the emergency department? I know you spoke about troponin to see if there is any myocardial involvement and also to rule out kind of ACS and doing an ECG. Would you do any other investigations in the emergency department?
So as I said, investigations will be done to rule out other potential diagnosis, warning diagnosis. We often do a chest X-ray, a troponin CS to rule out concomitant myocardial involvement, concomitant myocarditis, inflammatory markers, CRP, full blood count. And it gets done as a panel essentially. So troponin, chest X-ray, and if you're worried about PE, then yes, D-dimer. We'll check the pre-test probability before you do that. Obviously, we should put the probe on everybody's test who's coming with, if you're thinking pericarditis, to see for pericardial effusion. Coming back to your previous question, did I mention the causes of chest ST elevation? The other potential causes of ST elevation, which can be left bundle branch block, or it can be LVH, or Prinzmetal's, or Brugada, or hypothermia, hyperkalemia, PE can cause that. Essentially, lots and lots of things. Myocarditis can cause this, can cause ST elevation. So we should always correlate with the history. Every ST elevation is not STEMI, it's just ST elevation. Benign early repo is just ST elevation, and young men, the degree of ST elevation is important. Young men in 30s and 40s, they're allowed to have a fair bit of ST elevation, about 2 millimeters in their precordial leads. So it's important to correlate with the history. And if they have any reciprocal changes, that's obviously concerning.
Yeah, okay, perfect. So coming to disposition of these patients, who do you think can go home when you diagnose pericarditis and rule out most of the other things? And who needs to come into the hospital? So who needs to be admitted to the hospital?
I think it all comes down to, like we talked in Syncope, or one of the Syncope studies that we did. So it all comes down to risk stratification, who is high risk, who is low risk. If they have any comorbidities, like if they are immunocompromised, if they are on immunomodulators, or if they have history of connective tissue disease, yes, they obviously come in. If they've got temperature more than 38, yes, they come in. We'll leave a link again with the from the European Society of Cardiology guidelines. There's a flow chart which kind of really nicely summarizes who is high risk, who is low risk. So essentially, if you want to remember the key points that brings somebody in, is temperature more than 38, no response to NSAIDs within a week. If they've got, if they are on anticoagulants, if they've got history of trauma, connective tissue disease, yes, they end up coming into the hospital to figure out what has caused this. Obviously, renal related uremic pericarditis will also should be discussed with the renal medicine or nephrology, because they should start dialysis if they are not on dialysis. And if they've got obviously a cardiac tamponade or a significant effusion, that buys them an admission as well. Small effusions, it's a bit controversial. They can go home, obviously, after discussion with cardiology.
Perfect. Okay. So coming to the treatment, it's obviously if there is a obvious cause, then obviously we need to treat the cause. But if it is thought to be viral or idiopathic, how would you treat pericarditis if they're not coming in, if they do not meet any criteria to be admitted? And if you're sending somebody home, how would you treat them?
So if we don't find any, if history is straightforward, they don't have any other comorbidities, we don't really dig in for the cause. Every time we presume it is idiopathic viral pericarditis, which is the most common cause. The treatment is 3 medications that we often use. One is NSAIDs, other is colchicine, and the third one is steroids. Most people just put them on NSAIDs to start with for a week or a couple of weeks, and they need to be not analgesic doses, but anti-inflammatory doses. Like 800 milligrams of ibuprofen every 8 hours, and then taper it down about a week, couple of weeks. They should ideally be reassessed in a week to see the response. And if they don't respond well, we should probably speak to cardiology or reconsider our diagnosis. Typically, we start them on NSAIDs if they're going home. The guidance actually suggests if you can put them on colchicine as well to start with, because that decreases the recurrence. But most people respond very well to NSAIDs. The problem with colchicine is it's a drug with narrow therapeutic index. It inhibits the function of your neutrophils, inhibits the migration of your neutrophils. The neutrophils, the tubes don't reach the site of inflammation. It can be toxic. It can cause bone marrow suppression, myotoxicity, AKI. It's sort of, and we don't generally prescribe these medications from A&E, and it should be prescribed for 3 months if you're starting. I would definitely speak to cardiology if somebody has got that degree of symptoms, severe symptoms, and if I'm pretty sure about diagnosis, I should probably arrange some kind of follow-up for them if they are being started on colchicine, and they should probably be discussed with cardiology. If they have minimal symptoms, I would just put them on NSAIDs and get them home and ask them to see a general practitioner or come back to A&E in a week if they are not feeling better during the morning hours, so we can discuss with a cardiologist. And the other medication is steroids. Again, they are really outside the realms of emergency medicine. We would not typically start somebody on steroids unless they have other contraindications for NSAIDs. They can increase the recurrence. They are contraindicated in infections, infectious pericarditis like purulent or bacterial pericarditis. The times when we should think about steroids is when they've got connective tissue or autoimmune disease-related pericarditis, recurrent pericarditis, sometimes in uremic pericarditis, but again, this should be discussed with nephrology. So typically they're not started. So if you want to remember one medication, that's NSAIDs. The thing to remember about NSAIDs is they are anti-inflammatory doses, not the analgesic small 200, 400 milligram doses. Big doses, worth giving them PPI, pantoprazole, or your favorite PPI for gastroprotection. Other thing that we should probably mention to them is to restrict physical activity. It is recommended up to 3 months if they are athletes to restrict physical activity, but probably less for somebody who's not an athlete, maybe a month or 2, but typically 3 months of restricted activity for athletes. And so rest, NSAIDs, colchicine, and steroids, these two should probably be discussed with the specialist
team. Perfect. That makes sense. Coming to the complications, what complications can you expect in somebody who is diagnosed to have pericarditis?
I think pain is one of that. It's not really a complication, but long-term pericarditis can cause bacterial infection or purulent pericarditis or constrictive pericarditis that can interfere with the systolic function of their heart. The other thing is they can have tamponade if that's not treated, but that's essentially, that's rare. So purulent or constrictive pericarditis is one of the complications. That generally happens if they have other comorbidities, bad infections like tuberculosis that you mentioned, or other connective tissue diseases. They can have big pericardial effusions. And the thing with pericardium is if the fluid accumulates slowly, which often happens in malignancies, pericardium can actually accumulate up to a liter of fluid. And in trauma, they can decompensate with a few 100 mils, 100, 200 mils of fluid. They can go in shock. But if they have malignancy-related pericarditis or connective tissue disease-related pericarditis, it can go up to a liter of fluid in the pericardium.
Okay, perfect. I think we have covered most of the things. Do you want to add on any more points?
I think that's pretty much, just to summarize, your history, ECG changes, and your pericardial rub and echo gives you the diagnosis. It's always important to consider other differentials like ACS. You don't want to miss that. Do a troponin for them. Rule out myopericarditis, which is again an indication for admission. And treat them with NSAIDs. And that's very much.
Okay. Thank you very much.
Thank you. Bye-bye.